Hi, everyone. Thank you for being here today for our webinar, Methamphetamine Use and Infectious Disease. We have some really excellent presenters, Dr. Tim Menza and Melissa Cross. I'm Allison Newman. I work at the University of Washington Addictions, Drug, and Alcohol Institute. Really excited about this presentation today. So we'll go ahead and get started. Next slide. So only panelists and hosts can share video and audio. This is Zoom webinar. Please enter your comments and questions in the chat and Q&A. Be respectful and curious. And this webinar is being recorded and will be shared here by tomorrow. So we have a webpage for this series called Focus on Meth. Everything will be posted there. Slides will also be available on that page. Next slide. This series, we've been covering a whole bunch of stuff related to meth all year. First webinar was on overdose trends and reasons for emergency department visits. We had a great presentation on harm reduction at certain services programs and in primary care. We had a really nice presentation from my colleague Ben Beaumont and Leif Lehman on what's in the meth results from WA Community Drug Checking Network. And then today, we've got our infectious disease webinar, upcoming webinars, our meth use among men who have sex with men, and our June 12th methamphetamine symposium. So I'll put some of those links in the chat if people want to check out that series or sign up. Next slide. All right, I'll hand it off to my wonderful presenters to introduce themselves and get us started.
Hi, everybody. Thanks for joining us this afternoon. My name's Tim Menza. I use he and they pronouns, and I'm coming to you from two places, well, simultaneously. The University of Washington, where I'm with the Division of Infectious Disease and see people living with HIV, as well as the Sexual Health Clinic of Seattle and King County's Public Health Department. Melissa?
I'm Melissa Cross. I work at Blue Mountain Heart to Heart in Walla Walla, Washington, so all the way across the state from Tim. We are one of the pilot sites for the Health Engagement Hub model, so we offer harm reduction services along with primary care and addiction medicine here, and drug checking.
Okay, so you're going to see a little bit of a theme to this webinar, and syphilis is going to make a lot of appearances here. And so we're going to just talk about syphilis to start, kind of as a motivator around talking about the intersections between methamphetamine and infectious disease. And since 2020, as is the case across multiple jurisdictions in the United States, after about a decade of this like sort of slow increase year over year, the number of cases of syphilis really sort of exploded exponentially in 2020 in Washington state. And what we've also been seeing very concerningly is that cases of syphilis among people who can become pregnant and pregnant people also rose precipitously, leading to a five-fold increase in congenital syphilis cases just from 2019 or 2020 to 2021. And in Washington, looking at this intersection, methamphetamine is the most commonly reported drug among people diagnosed with early syphilis. And by early syphilis, I mean the symptomatic stages of syphilis and that asymptomatic stage that's just up to a year, or called early latent. So those three stages of syphilis. And so overall, about 20% of people who were diagnosed in Washington state with early syphilis in 2023 in Washington reported methamphetamine use. And you can kind of see that's been sort of creeping up over time. It's the light blue line in this left-handed slide. And under the dark blue line, which is sort of any substance use. And it sort of really surpasses both injection drug use, heroin. Fentanyl is not on here, so that's an important omission here, but one that is also contributing, but just not as much as methamphetamine at this point. And then in King County, 37% of heterosexual people diagnosed with syphilis in 2024 reported methamphetamine use in the prior year. And 43% of cisgender women who were newly diagnosed with HIV between 2019 to 2023 also reported methamphetamine use in the prior year. So then we sort of telescope out to the US in general, looking at substance use or patterns of substance use among people diagnosed now with just primary and secondary syphilis. So those are the first two symptomatic stages. What we're seeing is that overall, methamphetamine, again, is the most reported drug among people diagnosed with syphilis. And it kind of differs by gender. And here we're kind of conflating sex and gender. I apologize for that conflation here. These are the CDC data, so it's hard to tease some of these things out. But women are reporting, or 17% of the women diagnosed with primary secondary syphilis in the US in 2022 reported methamphetamine use. 15% of men who have sex with women, and then 7.3% of men who have sex with men. And that's kind of in the middle there. What I then want to draw your attention to, and we're going to sort of spend a little time on, is that over a third of folks across these categories are reporting sex while intoxicated or high. So let's kind of explore that sexualized drug use a little bit more. And drug use before or during sex can be used sort of for several reasons, right? Enhances sexual pleasure, expands sexual boundaries. There's increased senses of connections and intimacy. People have more confidence, more energy. It really sort of blocks out everything else in the world so they can concentrate on the experience. And it also helps people just focus and cope with some of the negative experiences and trauma, maybe around sex or just in general in their lives. Unfortunately, outside of Europe, where this sexualized drug use, specifically, they call it chemsex, and that term has kind of made its way into the U.S. too, into the lexicon, especially, well, mostly in academic circles, to be honest, but also called PNP, party and play, that sort of piece of things. The data is kind of sparse, especially among women, and we see that the most commonly impacted communities, or at least the folks who upon which there's data, and even then there's not very much, include gay, bisexual, and other men who have sex with men, and people who trade sex. And when we kind of bring this back to sort of our topic of crystal methamphetamine, it's one of the most commonly used drugs around sex. There are others that we're not going to kind of get into detail around today, but I just put them on here for thoroughness. But when we're talking about methamphetamine specifically around sex, we talked a little bit, I sort of gave you a teaser of like why people use drugs with sex, but specifically for methamphetamine, there's a lot of energy that comes with it. The sexual stamina is great, the sense of euphoria, and a lot of sexual arousal. So sex on meth feels really good. There's increased sensitivity to touch. The perception is heightened. Folks can go longer. The ejaculation doesn't happen and orgasms can be prolonged. Again, confidence and sort of reducing the fears, insecurities, and all the worries that can kind of come down on a sexual experience and kind of hamper it. But of course, there are potential harms, right? Overamping, we know that. We know that there's a lot around sort of paranoia, delusions, hallucinations, things that this is a drug that can amp up people's anxiety, sort of aggression. Folks go without sleep, right? Without eating, without nourishing their bodies, without drinking. And sometimes, all those great boundary expanding experiences that people have, sometimes it's like, oh, wait, maybe I didn't want to do that, or that was maybe a little bit too much for me, or I really went out of where I was expecting to go. And so that can happen. And then the other piece is that after sex with meth, sex without meth is hard. And so there's sort of a relearning around that has to happen. So again, benefits and potential harms of methamphetamine use with sex. And one of the other things to talk about is like how folks use it during sex. And this could be either sort of associated with sex or not. And I know this is not sort of specific. We're not kind of going to talk specifically about sexualized drug use per se, but this is an important thing to kind of bring up when we're talking about methamphetamine. But injecting or slamming, people can smoke it, can snort it, can eat it. Nasal insufflation is not necessarily a way that people use meth, but then booty bumping or boofing is another way. And each of these has sort of its benefits and risks associated with it. And so when we now expanding sort of more to the infectious disease part of things, if we think about use by injection, it's kind of important to think about all the different possibilities of infections that could result. And they kind of range from sort of bacterial infections, fungal infections, and these can affect the skin, the bones, the joints, the heart, the spine. They can be present in the blood, but also the viral infections that we commonly think about, like HIV, hepatitis B and C, and the particular types of infections. And for folks who want to geek out over the micro, it's like right in the middle here, and it's kind of fun. I mean, it's kind of interesting because they're like tied to the different injection practices. So in the particular types of practice of infections and the bugs or the bacteria, the fungus or viruses that cause those infections can be linked to different parts or steps in the injection process that include the quality of the drugs. It can include the water used to dissolve the drugs, the acid sources, right? Are you using lemon juice from an actual lemon, or are you using it from a bottle, or are you using like a sports drink, which is not uncommon. The needle preparation, right? Some folks will kind of lick or use saliva to lubricate the syringes or the needles. The skin and hand cleansing prior, and then sort of the sharing of equipment. So when we think about kind of harm reduction, there's, of course, it's sort of every step. And what I want to kind of emphasize is that each of these, what's here in this table and what was here in that sort of the end of this table on this side, sort of all the different steps, they're kind of really sort of like these individual level things that people can do to reduce their individual level risk of infections. But I want to also emphasize that sort of with this these circles, that there's also a whole host of like other macro environmental factors that kind of are at play here, right? So and like housing, like the availability of syringe service programs, transportation access to clean water to dissolve drugs, right? Access to restrooms, showers to cleanse one's body, the local drug supply, and then policies around drug use, incarceration. One of the things we bump up against, especially when we'll talk a little bit more about congenital syphilis, is like recovery programs that allow families. So all of these, even though we sometimes we focus or we have these particular practice that we want to encourage folks to do, there's a whole host of other things that are sort of conditioning how people can or how safe people can be. And this is just kind of some comprehensive care. I don't want to just to note that there's more to this than just injection practices or things around substance use, that people need comprehensive care. People who need drugs just need comprehensive care. And with that, kind of thinking more about harm reduction, I'll pass it back to Melissa.
So I know we already had a previous webinar that talked a little bit about harm reduction. I wanted to just note the 8 basic principles from the Harm Reduction or National Harm Reduction Coalition. Really, it is a pragmatic approach, which they talked about. We want to acknowledge and recognize that risky behaviors are going to occur, so we can intervene and help reduce those harmful effects by educating people and allowing them to have greater autonomy on the choices and decisions that they make. And that leads right into the human rights and dignity is at the basis of all harm reduction practices. We're always going to respect somebody's ability to make their own choice and always treat them with dignity and without judgment when they come to get services from us. We're focusing on the harms, not the actual use. We really try to maintain like an agnostic approach. We're just looking at prioritizing reducing the negative consequences instead of just coming from a patriarchal lens that they just need to stop using drugs, which is often an experience they get at other areas in their lives. We really try to use evidence-based strategies. Harm reduction is pretty neat. It's, a grassroots history. It's managed to be pretty responsive, and the ability to be responsive to this population means that we have to have a relationship with them and we have to know what's going on so that we can find things. Safer smoking supplies was kind of a response in the harm reduction community to the change in the drug supply that we are now having some evidence around, but originally it was kind of like, this is happening. What can we do now? We really try to be non-coercive. We do a very patient-centered or participant-centered approach about talking with them and finding out what their goals might be, and then scaffolding what those goals might be to get to the next phase. I don't come from a point of view where I think I know what is best for them or their lives. They are the expert on their lives, and we want to acknowledge and respect that. It's also, harm reduction comes from the principle of community involvement. So we talk to people who are most affected by these things, right? We talk to people with lived experience, and have them help us design and implement harm reduction strategies. So like, even though some of us, might have a history of a substance use disorder, I'm not in that community on a regular basis now. So I need to continue to talk to the people who are being most affected by these things. We really try to be accessible and non-exclusive. We want to make harm reduction supplies available, or harm reduction services available to everybody. That's part of the health engagement hub model that we're using for primary care, where we're really trying to offer medical services in a new way for people who have had barriers and difficulties for a whole host of reasons accessing traditional models, and have just gotten really tired of hitting their head against a wall, or coming in and feeling stigmatized and judgment. They walk into our clinic here. I'm always happy to see them. We also have the medical contract at the jail. I'm also happy to see the people who come into the jail, give them a smile and a welcoming approach. Harm reduction also really tries to be holistic. We, like Tim was saying, we really want to try to address those broader social determinants of health. So we have a lot of like wraparound case management services are really helpful to help with things like housing. Housing is so huge and integral for someone to be able to, live their life well. But also, employment services, mental health services. I can't tell you how amazing it is to have a bunch of social workers here able to address other things that might not be clinical in nature. Tim? I guess I can go on. So
Yeah.
I am very lucky to work in an organization that actually comes from a harm reduction history and then added clinical. So I know that there's some new legislative changes that now allow primary care to offer harm reduction supplies, but we kind of came the other way around. So this has always been available for us. And I think it's been an amazing avenue. The ADAI does a survey with syringe service participants in Washington State every 2 years. And, one of the big asks that's come out over the years is like, would you get primary care, other medical services if you could at SSPs and harm reduction programs? And that was like a resounding yes from participants, because they had that relationship. We were consistent, and we had proven a trustworthy nature with us, that they felt comfortable talking to us about what was really going on. So these are some of the things that are offered at our program. You see the safe injection site or safer injection kit there. We really try to make it an approach of, coming to like a Walmart or something. Like, you have a variety of supplies available, different sizes and gauges of needles, people might use in different ways. We also started offering safer smoking kits, I think about three years ago, and we offer a variety of types. There's a bubble there, a stem, or I think, what else do they call it? They call them lots of different things in different areas. You kind of figure out what the vernacular is where you're working. And then there's a hammer, which is actually has some interesting history of being created by people who were using heroin. There's filters and different things that go along with that. And having these supplies allows the start of a conversation around safer use practices, about how are you using, why are you using it that way? And, we learn as much from the people who come talk to us as they learn from us oftentimes. Okay, next. Tim was talking about different routes of administration. So in response to that, we were able to create these other kits. One of them is a booty bumping kit, or boofing kit. So it has 2 syringes, needleless syringes in there with some lube and some waters to be able to mix your drugs up. And then we always put instruction guides for people on how to use these things. Booty bumping is kind of an interesting conversation to start with some people. It feels like a topic that people are uncomfortable about. So we just kind of have them out there, and people can discreetly grab a little kit within it. And, oftentimes I'll just give it to my friend, but it's a great alternative, especially if you've lost access to injection, and it on this spectrum of harm reduction, it is a safer way to use than injecting. And then we also have a safer snorting kit. So these are straws, and it's like a plastic looking, what's a razor blade. And then I think we had this in a previous webinar in this series, just talking about oral health with stimulants. So adding some gum into those packets as well, and saline rinses for your mouth. And especially if you are doing chemsex and PMP, you can take some of these things so you have these supplies available for you during that.
And then sort of linking back up, thank you, that was great. And yeah, people don't like to talk about butts, but we like to talk about butts. And so in terms of the sexualized drug use and its associations with STI, Hep C, and HIV, there was just some data. There's sort of a large meta-analysis of 19 studies that a group did just to kind of look at these associations. And as you might imagine, there are associations between both bacterial STIs, including gonorrhea, chlamydia, and syphilis, hepatitis C, and HIV in relationship to sexualized drug use. One thing I'll point out is that there's a little bit of a difference between like HIV treatment and PrEP in terms of in its relationship to methamphetamine. And methamphetamine use seems to be fairly associated with not being able to kind of stick to an HIV treatment plan and achieve viral suppression. And we know that viral suppression is really important, not only to the long-term health of the person living with HIV, but also to reducing rates of transmission. But at the same time, data are actually mixed around whether or not folks use meth around sex or in general on how that affects one's ability to take PrEP. And so when we think about kind of the pathways, and this is a really busy slide, but this is sort of what the folks propose. And so initially, so if we start on the left-hand side, that the SDU piece is that sexualized drug use, right? And if we'll just go across the top there. And so there's the disinhibition, impaired decision-making, and the pathway A is like, condomless sex, right? And so I think even though this was published in the, fairly recently, it's a little outdated because condom use is not very common, right? And so what I would add to this mix also is like, so sometimes the drug use kind of makes it difficult to keep up with antiretroviral therapy, PrEP, doxypap, right? So those things, those interventions that people can use, not only to keep them HIV or STI free, but also achieve viral suppression for people living with HIV. But also, and we'll talk about this a little bit more a little later, but also just kind of the stigma and the discrimination and the inability, like the access to healthcare and services is really affected by the way people are treated, both past and present around their drug use. So they may not be accessing services that could reduce their risk of, and the STBBI is STI and bloodborne infections. So HIV, STI, and hepatitis C. So I think that's important also, right? There's that, direct pathway, which I think is maybe a little outdated here, but we need to kind of think about all the things that kind of go into that pathway. But the other thing too to think about is that, especially methamphetamine, there's some physiologic effects. There's maybe some changes in the mucosa. There is also, sometimes sex can be a bit rougher. There can be microabrasions and tears of anal tissue or penile tissue or vaginal tissue. So that might also contribute sort of biologically to the transmission of STIs and HIV and Hep C, of course. And then, we also want to think about sort of the sexual networks in general that people are participating in. And then finally, again, thinking more about the syndemic drivers, right? Things like stigma, isolation, shame, that also both might contribute to sexualized drug use and the things that people are trying to avoid or cope with, right? But those things may also drive transmission, especially around how they sort of prevent people from accessing or using the services that might be available to them due to discrimination. One thing that's interesting, it's a fairly recent article, the second one on the list up above or underneath the title here by Sherman and colleagues. They actually looked at a large database, the National Survey on Drug Use and Health, and they looked at among people who use methamphetamine, right, there's an increased risk of STI. But then among the folks who actually sought drug treatment, and they didn't say specifically it was for methamphetamine or what, they did see a reduction in that risk of STI. So there's some evidence that getting into treatment or being able to access treatment may also moderate that association between those two things. And the other thing that on the right-hand side here that I put in, this is from King County, looking at the clinic and comparing folks who use methamphetamine who started PrEP versus folks who don't use methamphetamine who started PrEP. And it does seem like the discontinuation rate is a bit higher over time. And so again, sort of just driving home the point that that might be both due to accessing or ability to access services or the acceptability of those services. So just keeping that that delivery in mind. And then I'll pass it back to Melissa.
So one of the key things to be able to, offer some of these services and have these conversations with people is our use of language. So I just wanted to kind of briefly put in a slide for reference later about how we can decrease stigma. We don't call people in our practice necessarily addicts, or we talk about people with substance use disorder, junkie, crackhead, and same when we're talking about like crack babies, we have neonatal abstinence syndrome, things like that. We want to just be really careful about that. I will say that oftentimes, it doesn't mean that I am being the language police and correcting my patients on how they want to identify who they are. Some people have really found power in reclaiming that word addict. So I'm not trying to be language police, but I do want to move the needle on how we refer to people, because even in the community, when I'm talking to people who aren't involved in this kind of work, I want to be as non-stigmatizing as possible. It's also a moving target because, I've been doing this work for 7 years now, I guess. And it seems that, I will still learn new things about better ways to say things, even in my chart notes, how I chart, right? I used to always say no illicit drug use, right? And I was trying to figure out that was stigmatizing. And so, recently I've made the switch to saying, denies non-prescribed drug use or something like that. But, every time we kind of change a term, then that term eventually gains the stigma and we change it again. But just being really conscious of the words we use with people so they understand that we're here with them.
And then thinking about, some of the harm reduction strategies related to sexualized drug use. I have the other thing, and these are fairly general. I can share a resource also around, we're not sort of necessarily talking about sort of sex parties or places where drug use is happening where there are sort of multiple people and there's a specific space, but there's even more ways folks can sort of engage in harm reduction activities in sort of those settings. But definitely thinking about, and sometimes you can do this with your patients too. It's like talking about what guidelines or boundaries they want to kind of set. And sort of thinking about the timing, again, also putting sort of numbers on, the maximum amount of time or the doses per occasion. Again, using test doses or, maybe not mixing things. And then having access again to, as Melissa sort of described, the sterile syringes, needles, works, also smoking supplies, booty bumping supplies, other ways that might reduce the risk of, say, injection-related infections. And important to, again, sort of the self-care piece is also really important, taking breaks, eating, hydrating, and also like the timing, right? You may not want to do it on a Sunday night when you have to go work on Monday. And thinking about whether or not, there's a group of folks that you kind of want to stick to rather than sort of new folks all the time. And then making time to kind of work in all the medical checkups and routine care, working in taking, PrEP and HIV medications, doxy-PEP, and really also thinking about oral care too, especially around methamphetamine with the reduced saliva production.
And this can be a really big conversation that someone might not be ready to have with you when they first
Yeah,
meet you, right? They might just want to know their
yeah,
status and go on their way. But over time, you can develop this and you can, help them coach this and pre-plan this, which is actually really similar to what we do in addiction medicine when we talk about like, what are you going to do when there's a craving or you run into somebody on the street? If they feel that safety and trust to be able to be like, I'm planning to do this thing, and we can talk around it. So it's pre-planned beforehand and they have the supplies they need. And then they, have this experience, they come back, they tell you about it, and then they get ready for, whatever comes next.
yeah. And I think, Melissa, you said something really wonderful in our meeting yesterday. Like, you don't owe anybody the story. Like, your patients don't owe you a story or a backstory as to why they're accessing X, Y, and Z. And that's important to kind of keep in mind. And maybe it'll happen over time, maybe it won't,
Yeah.
but
And this
yeah.
particularly, like the people we work with are put in a lot of like carceral settings, legal settings, rehab settings where they're just, you know, hi, my name is, and I am going to be doing your intake. And they're asked very invasive questions and kind of, it becomes this pseudo barrier to care that I have to disclose these very, traumatic parts or things that I have a lot of shame around in order for you to help me. And I really try to get away from that in our own practice here, that they don't owe me their story to get the help they need. And I think that really goes the long run of developing and building that relationship over time that actually is like the primary driver for people getting healthcare and continuing to seek the care they need.
And now just sort of taking a focus on congenital syphilis for a second, just because I think this is such an important piece. And congenital syphilis is a public health emergency. I want to be clear about that. And the increase in syphilis in pregnant people and congenital syphilis, is kind of staggering because not one case, because it's preventable, and not one case of congenital syphilis is acceptable in a modern healthcare system. And the thing that I feel like sometimes gets lost in the data, are the number of infant deaths and stillbirths due to syphilis. And this is sort of looking over time from 2014 to 2023. And I will say that about 10 to 15% of all infants born with congenital syphilis die, right? And I don't know how much we, really talk about the mortal consequences of congenital syphilis. And one of the things that we started to do, I used to work in Oregon. And one of the things that we did, we were really kind of interested in sort of both sort of individual level and sort of larger, we looked at the county level predictors of congenital syphilis in Oregon. And we followed this thing called the county health rankings model. And we looked at things like mental health, the number of poor mental health days, health behaviors, which some of these classifications aren't exactly like, they don't actually fit the variables, like, but food insecurity, methamphetamine overdose deaths, things like unemployment in the county, poverty, adverse childhood experiences, violent crime, and then houselessness. And when we took all these factors together, we kind of put them into a score. I'm just sort of highlighting all the pieces again. And here's kind of the I'm not going to dwell on this, but just sort of like where we got all the data from for the score. But when we look, we see that in congenital syphilis was people who resided in counties with greater, what we call them socioeconomic behavioral health challenges. So if a county had greater socioeconomic or behavioral health challenges, there was a greater chance that a pregnant person would have or would be associated with a case of congenital syphilis. And when we combine that also with some of the individual level factors, these are things that we got from that surveillance system. So the detail on the data is not very good insofar as we're kind of using things like ever injection drug use or ever been involved in the carceral system. But when we put all these things together, what we saw is that residing in a county with these greater socioeconomic or behavioral health challenges increased the proportion of pregnant people associated with congenital syphilis by 22%. People who used injection drug use, that increased it by 88%. And then carceral system involvement also increased the risk of congenital syphilis. So when we kind of contextualize that or put that into a sort of greater narrative around congenital syphilis, syphilis in pregnancy and congenital syphilis is really part of a larger crisis of morbidity and mortality among birthing people in the U.S. And I'll kind of show you this a little bit more, especially among Black and Indigenous folks. And it's really a symptom of an under-resourced public health infrastructure and workforce, which is only contracting even more and may get contracted sort of dramatically in the next few weeks and months and years. And congenital syphilis really occurs at this nexus, right? This nexus of poverty, houselessness, structural racism, trauma, substance use, and mass incarceration. And so when we think about this, and this has kind of been our theme the whole time with the social determinants of health too, a response that only focuses on congenital syphilis won't end it, because all policy is health policy, right? So one of the things that I want to point out here to kind of draw these things together is when we look at maternal mortality in the United States, we see a story essentially of dehumanization, right? And so what I'm presenting here on this top slide is pregnancy-related mortality over time, but like pre-pandemic, post-pandemic, essentially. So where the light blue is pre-pandemic 2019, just before to quarter one of 2020, then pandemic of 2020, and then 2021 as the bars get kind of darker, with the dark blue being the 2021. What I have underneath, and so what you can see, right, is that maternal mortality increased through the pandemic, but it increased sort of dramatically among Indigenous folks and Black folks in the United States. And so what I did is underneath this, this graph, I've juxtaposed this with a really harrowing report of discrimination and mistreatment during pregnancy by race and ethnicity. And so you can see kind of across the board, which is sort of stunning to me, is that mistreatment is actually quite high, period, right? But then when you look at Indigenous folks, and I'm here, sorry, grouping both American Indian, Alaska Native, Native Hawaiian, Pacific Islander folks, because they weren't separated in that study. So when I say Indigenous, it's a sort of a larger net or umbrella. Here, Hispanic and Black pregnant women, experience sort of very, very high rates, 20 to 30%. And when you look at actually what folks reported, and I just pulled out sort of just a little bit on this, because there's a whole host of things that folks reported, but being shouted at or scolded, being ignored, and actually experiencing physical abuse at the hands of their providers, right? So this is mind-blowing, right? And then when people, the high levels of discrimination that are also part of this equation, right? So again, like almost 30 to 40% in the same groups, Hispanic folks, the Indigenous folks, and Black pregnant folks. And when people were asked about what they were kind of discriminated against, I'm going to kind of read this off a little bit. But right, it included things like race, like socioeconomic status, like substance use, like weight. And so all of these things, so then when you have this story of mistreatment and discrimination, once you juxtapose it with maternal mortality, and then over here, kind of just another echo of what this is all resulting is the congenital syphilis piece too. And so as you sort of take the thread from discrimination and mistreatment to congenital syphilis to maternal morbidity and mortality, you see that these things are all connected, right? And so no wonder, so one of the pieces of this is that no wonder people don't necessarily access healthcare. And one of the specific pieces around this, especially that we found in the Oregon data around incarceration, is that the carceral system was a big part of this. And because medicine and public health use the carceral system to criminalize pregnant people. And again, these are all viewpoints of my own. So these are not sort of UW or Public Health Seattle County viewpoints. I'm going to say that they're just my own. That the carceral system just shouldn't exist, right? It's racialized, right? Like we see how that discrimination and mistreatment is racialized, right? It's a destructive force. And it extends these legacies of chattel slavery. And the thing is, this is not sort of olden day stuff, right? California's Proposition 6, which was on the ballot just this last year to take slavery as a punishment for crime, right? Incarcerated people failed, right? They upheld the use of slavery as punishment for crime in California. In Oregon, when this same bill was up, it just narrowly passed, right? So these are things that are sort of in the mix now, right? And also kind of this, and it upholds the legacies of Jim Crow. And I love this book by Michelle Alexander. I encourage everybody to read it. But also these things called mandatory reporting laws. I'm getting there. I'm getting back to the drug use piece, I promise. But the mandatory reporting laws, the child protective services, and other forms of family policing are just extensions of the system, right? And oftentimes medical care, when people present to care, when pregnant people present to care, when pregnant people who use drugs present to care, it's been basically used to criminalize or incarcerate pregnant and birthing people. And killing the Black body has a lot of accounts also around sort of the crack use, and where, just stories upon stories about how folks, when seeking care, wanting to be honest, get punished, right? And so the threat of the carceral system really impedes prenatal care access, especially for people who use drugs. And so because that access to care would result in further stigmatization, mistreatment, discrimination, and potential recriminalization. And so what drives this home for me is that when we look at opportunities to prevent congenital syphilis in King County, we find that almost 60% of people are diagnosed at delivery because they didn't get any prenatal care before delivery, right? But it makes so much sense, right? Why would you? And so a lot of this does kind of circle back to kind of prior histories of, some folks in fact had CPS involvement as children, right? So they know exactly what the system's going to do to their kids. And then some folks definitely sort of the substance use piece, prior issues with the carceral system, all housing, right? So these things all kind of come together because pregnancy is policed so much. So this has sort of direct effects on sort of these congenital syphilis rates and our ability to sort of prevent congenital syphilis, so much so that the system really needs to kind of be overhauled. And we're kind of just trying as best we can to kind of support people through either pregnancy or diagnosis of congenital syphilis. But when folks just are fearful enough that accessing services is just too big of a risk, this is when we have these missed opportunities for a whole host of things. Congenital syphilis just being one of outcomes for pregnant people. So just kind of want to sort of make sure that that's sort of part of this conversation as we talk about substance use, methamphetamine specifically, and infectious disease, and how they're kind of related to syphilis and congenital syphilis.
So just piggybacking on that, I mean, he kind of has this big umbrella thing, but this happens regularly where we have a pregnant person present to us in their 8th month of pregnancy. They've been trying for those 8 months desperately to stop using drugs on their own. And now they're trying to figure out how to get sober before they give birth so that their baby isn't taken away at the hospital, right? It's this like sprint at the end without all of like the time to find housing or find all those other, factors that are also contributing to this. And when we talk about meth versus people that use opioids like fentanyl and things, they're coming in here because they know that there's medications that exist to help people with opiate use disorder, like maybe Suboxone's going to help, maybe, however we're going to, or Subutex in that case, however we're going to do that. We have like this medication we can offer them that's fairly well known in the community. People with meth are much less likely to present because they don't think we have anything to help. And that just makes it really tough for this lost population. We do offer contingency management services here, which is a newer behavioral treatment, but it's different than being able to offer a medication to help with those cravings and withdrawal symptoms. So, even within the drug using community, if you're primarily an opioid user or meth user, your likelihood to seek that help even towards the end of pregnancy is going to be impeded by, what we know about stimulant use and how we can help. When we look at engagement with healthcare services, like I said, I mean, people who use drugs want to get healthcare just like everybody else. They're just like all of us. But unfortunately, they've experienced a lot of that medical trauma that Tim was talking about, or just trauma with all sorts of institutions and systems in society, right? There's a lot of stigma and judgment. They don't have a lot of places where they feel safe to disclose things or talk about what's really going on with them. So being able to reestablish that like patient provider relationship is really important. It's also not going to happen instantly, right? This is a long road over time. We know that, having no insurance or high cost services is a serious barrier for everyone. We definitely see that in the carceral system where people's insurance is automatically suspended if they have medicated while they're in jail, which means any services or medications that they need while incarcerated get charged to their books, which becomes a fine that they owe to the county, and a whole, circular spiral that they get into. Another thing that can be really beneficial for people is that co-location of services. I think that's just really for all of us, right? If I could go one stop to my dentist, my doctor, and my physical therapist, and also get my mental health therapy, that would be awesome in one place. But instead, we have this system that is very specialized in these silos and has trouble talking to each other. And, that's hard for us as clinicians to even navigate, let alone someone who doesn't necessarily have a phone to remind them it's Tuesday for their appointment, or gas to get, and that in rural communities, that transportation, can be big. Like I have, two OTP methadone programs near me, which means it's an hour away in either direction. So if someone wants to participate in methadone treatment, that's 2 hours minimum, at 6 in the morning. And who's going to pay for this gas because they also need a job, right? So, and Tim's been talking about through this whole presentation that the structural violence and oppression are really big factors that feel so big and so hard to change, but we have to keep talking about them, right? We have some peer support people where I work with a lot of lived experience. I think sometimes that really helps for, people who are trying to access care to know that other people have also experienced this, right? And they can help them navigate them and show them ways that worked for them. Oftentimes our peer support people will just be like, do you know how to call the housing authority? Or I will sit down and show you how to apply for Medicaid. Those just weren't things that were modeled or learned for them ever in their lives. Another thing that we frequently run into, and I think this happens in a lot of different populations, is there can be a lot of cultural mythology around something. And even with a lot of rapport, that can be really hard to break through. Like that might also be a long game over time, that you might trust that I might know what I'm talking about, but that's okay. I'm not going to like fight with you on it, especially I don't want to be antagonistic. But, we saw this a lot around COVID vaccination with people who use drugs. We helped do some research for the CDC around it. And the most common theme for people who use meth was they had this idea that methamphetamine, like the chemical structure of it, somehow was protective against COVID. So they didn't need to get vaccinated. And that was really difficult, but you'll find those cultural mythologies that might be, very localized just in your small community, or more widespread statewide or nationally. But knowing what those mythologies are and having a good way to, what is your messaging back on that, that isn't trying to be antagonistic, still being collaborative, right? Asking why questions like, tell me more about why you believe that, and things can be helpful, but it still happens.
Tim, you're still on mute.
Sorry. I also just wanted to, there's also, we've only got 10 minutes, so I want to sort of make sure we have time for questions. But I'm just going to put these up on the screen in terms of just some experiences that folks have had pregnant postpartum people on methamphetamine use, and that kind of intersections with both CPS and trauma in general. And I see in the chat there's some really great resources. So thanks everybody for sharing those, including the first clinic. And I think I know that Allison's going to sort of put those all together, and we can probably share them out with slides and everything. But yeah, there are resources to help folks through kind of this process to navigate and prevent familial separation, which can be so traumatic. And then I think that's so then is this us, or are we going to ask the questions of the audience?
We can skip those questions because you've
Okay.
talked about them a lot, but
Yeah.
we don't have any audience questions yet, and that's a blank slide. So before we dive into questions, just want to say thanks to you two so much. I really enjoyed putting this webinar together with you, and please put any questions that anyone has in the chat and Q&A, and I will be compiling all the resources shared in this to put into the slides. So yeah, please enter any of your questions into chat or Q&A. And also Melissa and Tim, if you do want to add anything else, we do have a few minutes to give people time. There's a lot of hands clapping right now, so that's good. But anything else you want to add about engaging people, or anything else you think is relevant? Oh, we have a question. Where can we connect with you all?
Oh yeah, we can share our contact information. I can put.
Let's see. Oh, thank you so much. This was a great presentation. All I'm seeing is love and support so far, and no questions. We did have a question in the Q&A from Brian Ochoa earlier about whether methamphetamine use was more common than cocaine, and I was able to share that from what we see from Washington mortality data and from our Syringe Services Program survey, that at least it does seem like meth use is way more common than cocaine use in Washington. Hard to say for other places, because I'm not as familiar.
Right.
So, anyone else have questions? I feel like we covered so much. So
Yeah, anecdotally, from my experience, methamphetamine is just a lot easier to source than cocaine over here in Southeast Washington. So I do have people who would prefer to use cocaine due to the shorter time of action, but it's not able to do that.
yeah, and I see a comment in the chat. Thank you so much. Great information regarding the harm reduction kits available. I work in Spokane, Washington. Meth use seems to have increased recently. Yeah, I think we used to think of Spokane as having a lot more meth than Western Washington, but now it seems like it's everywhere all the time. So, and Ben Beaumont says meth is a whole lot cheaper and lasts a lot longer. Yeah.
Yeah, than coke. Yeah.
So,
do any of your presentations talk about what contingency management is?
we're going to have one as part of the symposium on June 12th.
Okay.
Thank you for the lead in. Yeah, contingency man. Do you want to give a little overview of what contingency management is?
So contingency management can be done in a lot of different ways. It's a behavioral health intervention where at my program, people come in twice a week and provide UAs. If they're negative, they get a gift card. If they're positive, we don't pay them for the positive, but it allows some accountability, and it's really not a large amount of money. It's more about that connection piece. And being able to have those conversations over time. It's been really popular with us and really helpful. Like, I love the fact that we do it. It's really helped us actually engage more meth users who do not use opiates into our primary care clinical services. Actually, is because they develop, they come in through our harm reduction SSP program, then they get introduced to contingency management. We can give them a resource for food, gas, that kind of thing that they need. And as they kind of get used to being in our space, then they might want to talk about like, hey, I have this untreated diabetes or hypertension, which we know comes a lot with, stimulant use, chronic stimulant use over time. And we're able to kind of move into these other more healthcare related spaces because of that entry of contingency management.
Yeah, thanks for sharing. And there's a question I can probably most easily answer, which is why wasn't fentanyl included in this webinar series, which is that at least syphilis use, which is what I wanted us to focus on is really rising fastest among people using methamphetamine and not as much among people using fentanyl. And there are different health issues. So it would be great to do a whole webinar on opioid use and infectious disease, but it would be a little different than what we talked about because sex and opioid use intersect in a different way. And the other consequences of like injection drug use would be similar. It would just be a different webinar.
Yeah. And I think there's a question about any info about change in mode of use from injection to smoking meth with smoking supply availability. We've definitely seen sort of more smoking, although I have to say among my patients who use meth, for the folks who use by injection, they like to use by injection, and have kind of maintained that. However, I actually very recently I have a patient who, and Melissa had mentioned this, sort of vein access is getting tough, and the number of infections, skin infections, soft tissue infections, just increasing. We're working on that. We're working hard on this, and so yesterday, or actually last week on Friday, I brought him a smoking kit and I brought him an injection kit, and I gave him both. I said, you do you. I said, here's what I got for you, because I also, anyway, I'll save another story for another time. But I was like, maybe you want to think about this for a second. And yeah, he's like, yeah, no, I think I really do. I think this is the time to think about, maybe switching to smoking over injection. And so that's kind of, and I also had another patient who had come in with sort of a neck abscess, and I was like, oh, what's that? And she had tried to inject there, and so I was like, okay, well, let's talk about other ways we can maybe think about using that it's not your neck. So yeah, give the flesh a rest. I like that. I love that. So yeah.
And we had one really, I think, useful comment from Ben Mina, and maybe that's how we say your name. I'm definitely a biased party here, given my role at DOH, but also consider adding immunizations to support someone's sexual health. HPV, oh, sorry. Someone else added to the chat, and now I lost where that is. But yes, immunizations, I think, are really an essential
Yes, we
piece.
do those here. It's lots of fun. As far as routes, though, the other cool thing about smoking or not injection is you can do some of these other kind of foundations of harm reduction of like starting low and going slow. It's really hard to do a test shot with an injection. Then you got to shoot yourself again. Like that just causes a lot of harm over time. It's a lot easier to try a little bit, smoke it, wait a second, and do a little bit more. So there's some benefits around, how you use too. That's helpful for.
And we've got a nice slant rhyme recommendation here. Give the flesh some rest is what I use to suggest smoking as an option. So I like that too. Nice notes about wound care. We do have a question. Maybe someone in the chat can answer, or maybe you two can. Have you studied, or do you know the prevalence of a harm reduction philosophy within DVSA advocacy services in Law State? Because I don't know. Does anyone know? If there's any harm reduction. Oh, and we're right at time. But does anyone know if there's, oh, here we go. Emily knows. So Emily Hurio has put a link in the chat relating to domestic violence, homelessness.
Thank you, Emily.
Yeah, it's perfect.
Emily needs to attend all our webinars to put resources in. So we are right at time. So I want to wrap us up because I know people are busy, but I just want to say thank you again so much for all your knowledge. And I love hearing about how much you care about your patients and clients and are really there for them. And the way you were able to communicate that in this presentation really came through. So really appreciate that. So thank you both so much.
Thank you. Thanks so much for having us.
Bye.